So in terms of treatments for prostate cancer, most commonly you'll see a radical prostatectomy, which can be done with a variety of approaches: open, laparoscopic, robotic assisted. Are we seeing a lot of open prostatectomies these days? Yeah, I can't tell you the last time I saw. It's been years. So most commonly it's that robotic assisted approach with nerve sparing or non-nerve sparing plus or minus a pelvic lymph node dissection. And for significant disease, an extended pelvic lymph node dissection. Cryotherapy, I think, also has fallen out of favor, but I did throw it up there. So, irreversible IRE. We'll just call it IRE. So this is kind of a new treatment option that's coming, where essentially the prostate is morcellated. So you may see some of those, the resumes and the brachytherapy as well. So for the radical prostatectomy, it's the removal of the prostate, the SEM. Again, most often you'll see that with the robotic approach. It seems like we're improving so much that this is moving towards completely an outpatient procedure. Medicare considers it an outpatient procedure, but it seems like most places throughout the country are still doing an observation level, or at least one night overnight. But I think that as care pathways are progressing, it does seem to be moving in an outpatient progression. In terms of post-op nursing assessment for these patients, you want to ensure that there's hemodynamic stability. So vital signs, a basic cardiac, pulmonary assessment. Look at the color of the urine. Certainly not uncommon to see some red or pink lemonade color urine. Ensure the urine output is adequate, at least 30 cc's an hour. Drains also seem to be omitted more and more. If a drain is left in place, check the output. How much is it putting? What's the color of that output? Look at the drain site. Do you see drainage from around the drain site, not necessarily going into the drain? Assess the capacity of that drain. Bladder spasms, anytime you can have a Foley catheter and you can experience some bladder spasms. So certainly help the patient understand what is a bladder spasm, what is pain related to the surgery. Sometimes it can be a little confusing for the patient to understand the differences between those two. Ask the patients if they're passing gas, a good indication of the return of bowel function. Incisions, if there's dressing, check to see if there's any drainage. Outline the drainage to see if any drainage is increasing. A good abdominal assessment, so palpate, throw the stethoscope on, listen to see if you have any bowel sounds. Feel the belly. Is it hard? Is it rigid? Is it soft? Kind of bang on it. Is it tympanic, indicative of some air in there? Ask the patient about their pain. What does it feel like? Does it feel like they just did 500 sit-ups, which is quite common? Does it feel like they have a stabbing? Does it kind of feel like soreness? Does the patient complain of gas pains? All things which are going to help to guide, what the next step may be. With the laparoscopic and the robotic approaches, the patient's peritoneum is filled with gas to blow them up during the procedure. So during the procedure, they almost look like they're 9 months pregnant, right? On the postoperative floor, a lot of that gas is dissipated, but inevitably it can remain. There's a number of studies that showed that the lower that you increase the gas during the operation, the less pain the patient has, which makes sense. So that might be a good collaboration with the surgeon and a good opportunity there. When the patient does have that gas, it does have a tendency to move throughout the body as the patient moves. So when the patient's laying down, it may be laying down with the patient, right? And then when the patient gets up, all that gas just moves up. A lot of times patients complain of gas in their chest, in their shoulder. Certainly, let the provider know if the patient has a cardiac history. You may want to consider going in that direction. But again, because the laparoscopic approach does involve pneumo, you can certainly anticipate some gas-related pains. In terms of post-op nursing interventions, so a lot of these are pretty applicable to all urologic surgeries, okay? So the basic core of post-operative care, out of bed and ambulate. There has been some preliminary studies that have shown that early ambulation on postoperative day 0 decreases the length of the stay and reduces complications more so than patients who ambulate postoperative day 1, for example. Chewing gum. Anybody have their patients chew gum after surgery? Yes, that's good. So, yeah. So chewing gum stimulates the cephalic vagal reflex, which produces the gastric acid, which helps to break down food. If the patient's not necessarily eating yet, it kind of is a sham feeding. It's tricking the body to produce that and helps the return of bowel function. Advanced diet. Some places have a soft post-operative diet, which is a little bit more friendly. A lot of the ERAS guidelines really show that we don't necessarily need to have the patient NPO until they have return of bowel function, that we can very safely feed them prior to passing gas. So a consideration there and an opportunity to review your protocols with your providers. For the patient that has a prostatectomy, you'll perform some urinary catheter leg bag teaching, have the patient actually do their hands-on. I think a lot of times we get very excited and we have hands-on, but at the end of the day, we're not going home with the patient. So having the patient have their hands-on and doing that as we walk the patient through it is really the best course. Teaching the patient how to care for their Foley catheter, cleansing their perineal area will certainly help to reduce infection, UTI, CAUTI. Giving the patient a splint pillow, teaching the patient how to move with good ergonomics, good pain control, utilizing non-opioids, non-narcotics, alternative medicines for pain control, music, relaxation. VTE prevention, so again, out of bed, ambulate, anticoagulants, and then antiemetics as needed. So it's also important to identify those potential postoperative concerns early on to prevent things from snowballing. So, first it's that hemodynamic stability. The patient's vital signs okay? Are we seeing that their blood pressure is significantly tanking from when you first got the patient? If the patient's passing large blood clots in their Foley catheter, or if they're jelly-like, jam-like, that's certainly a concern. If the urinary catheter is not draining at all, if the patient does have a drain, if they have high drain output, that could be normal, but it also could not be normal. If the patient did have an extended pelvic lymph node dissection, we do anticipate there to be a lot of lymphatic drainage through the drain, but if the patient did not and the patient's making 300 cc's of output from that drain, that is a little bit more concerning. If the patient has frank or thick blood from the Foley catheter or from the drain, that's certainly something that needs to be worked up immediately. If the patient has acute pain, if the patient's abdomen is firm, hard, distended, all things that are indicative of the patient bleeding.